Let's look at a beautiful veneer and crown case on maxillary teeth. This first episode will be prepping upper teeth. Now we're going to show this series as a Dental Minute video. Later on this year we'll be restoring the mandibular teeth, and we'll have it in the library of dentistrymasterclasses.com as a comprehensive case. So this is before and after. The veneers on the anterior teeth, crowns on the bicuspid and first molar teeth. Before I start in the morning, I always write down a sequence and a time schedule just so I generally know that I'm on time. Normally I see one patient every morning from 8 in the morning until 1 in the afternoon that are sedated, and we're doing some restorative or surgical procedure. So local anesthesia, you can refer to the link in dentistrymasterclasses.com on how to administer painless and profound maxillary or mandibular local anesthesia. That's such a critical part of dentistry. I see more new patients and they say, dentists could never get me numb. There's no reason that every tooth should not be as numb as a post if you go through the process, and an intraligamental injection along with infiltration or a mandibular or maxillary block is a part of that process. Also, linked to this, quick and easy rubber dam placement. This is a very fast way to place a rubber dam. And you think, what are the objectives of rubber dam placement? I want to keep the tongue, the cheeks, and the lip out of the operating field. So my assistant has a free hand, or I have a free hand, not having to use a mouth mirror to retract the lip, the cheek, and the tongue. She or I can be doing something else with that hand, instruments, blowing air on a mirror, and also it keeps 99% of the water out of the mouth, and it keeps any pieces of old filling or what have you from falling in the patient's mouth and having to worry about them swallowing it or aspirating it. So I use a rubber dam with this particular technique. It's not the conventional technique you learned in dental school on almost any procedure, even extractions, if they're not the terminal tooth in an arch. I'll use this rubber dam, and it takes me about 15 seconds to place it, and it will save you so much emotional energy, and the patient feels much better while you're working on their teeth because they're not having to worry about their tongue, their lip, their cheek, or about anything that you're working on falling into their mouth. So this is a quick technique. See, it's just one string right here, one line. They're not all individual. I'm first doing the crown preparations on the teeth that either had large fillings or cracks in the teeth. So we're placing crowns on the first bicuspid. The patient is missing a bicuspid on each side, so we're doing a crown prep on the bicuspids in the first molar, and then veneers on cuspid to cuspid. So I use a variety of different burrs for crown preps. This is a coarse football diamond, and I'm using it just because it preps faster than a coarse barrel diamond. Now remember, this is a hot tip. If there's gingival recession and you prep down onto the root of the tooth that's exposed, you may create a hypersensitive situation. So if that tooth is in the aesthetic zone and you have to do a crown prep onto the root, and you're going to actually remove a 0.5 millimeter or more of tooth structure, you'd better talk to the patient ahead of time about the fact that that tooth may end up needing endodontics. Now, if the tooth is not in the aesthetic zone, i.e. a maxillary molar tooth or a mandibular tooth, just keep the prep supragingival. Don't prep down onto the root. Remember, a crown or a veneer does not make a tooth less sensitive. If anything, it makes it more sensitive if you do more than just a roughening of that root surface with your burr. So you don't want to create a hypersensitive tooth that was not sensitive prior to the tooth preparation. Never forget, if you tell somebody something ahead of time, if you discuss it ahead of time, it's a reason. If you're explaining it after it's occurred and you didn't talk about it ahead of time, it's an excuse. You can see there's root exposure here, so I'm just going to barely touch that part of the tooth in the preparation. So this is a small chamfer diamond, just creating a chamfer margin So on the lingual of these teeth, or the palatal, that margin is supragingival. There's no reason to take it all the way down to the gingival line. On the facial, with the bicuspid teeth, I am taking it to the gingival line, but where there's gingival recession and the roots exposed, I'm just barely touching that part of the prep, the marginal part of the prep. See, I'm not prepping much up here at all, just lightly touching that. And then once I seat my veneer crown, I'll come back and polish that little edge on the margin, if there is a little edge on the margin. I'm keeping these margins supragingival interproximally. And again, this is the coarse football diamond, and I want about 2 millimeters of clearance if it's a crown preparation. They say 1.5 millimeters. Well, who can really judge 1.5 millimeters? I'd rather give my technician a little more space than too little. And the tooth is not going to know the difference if you give a 0.5 millimeter more. So I want about 2 millimeters of occlusal clearance when I'm preparing a tooth for a crown. Then this is the other side. See these teeth with large fillings? We're going to place crowns on those teeth. You've got a big crack on the second molar, lots of water, and I'm using a 330 carbide burr for my occlusal depth cuts. And that burr is 2 millimeters long, so if you put the burr entirely in the tooth, that's the proper amount of occlusal reduction. So I'm going to cut the depth cuts and then go back and connect the depth cuts with my occlusal reduction burr. And I use several different burrs for occlusal reduction. I'll use this one, or I'll use just the round, we call it a hat burr, or you can use the coarse football diamond. Then I'm going to come back with my coarse football diamond for the initial parts of my prep, just because it cuts quickly. And you can see the root exposure back here. So I'm going to keep this prep in enamel above or coronal to the cemento enamel junction on the molar. Now, most of the time I remove an old mercury amalgam. I personally don't think it's critical if the margins are clean. You know, if the amalgam's been on the tooth and you're doing the preparation and the margins are sealed and clean, you're going to be covering that tooth with a crown. And I personally have read a lot of literature on amalgams, and I think if they're covered with a crown and contained within the tooth, I think it's not essential that you remove the entire amalgam. Now this is isopropyl alcohol. Once I have removed it, I'm just going to clean it real well and then rinse it, and then I'm going to place an IRM buildup. I use IRM because it's easy to use, easy to place, and then I'll come back and fine tune the preparations. Mix it real thick. See how this is a supragingival margin. Since I have root exposure, I'd rather not prep down onto that root. If I have to, like with the bicuspid, I am, but I'm just barely polishing it. If you prep 1 millimeter into the root of a tooth, you better incorporate endodontics in your treatment plan. See, so this is the lingual, or the palatal. See, I've not prepped down to here, and I've kept both of them, of the preps, supragingival on the palatal because it's not in the aesthetic zone. Now I'm prepping the veneers, and you always want to include the interproximal and the incisal as well as the facial surfaces in your preparation. We'll put a link up here in a minute to wrapping, and I'm going to go through wrapping and why you want to do it, because if you're not used to veneer preparations, you'll think this is dramatic. It's not, and I'll show you why here in a moment. So I'm using a coarse barrel diamond for the facial reduction, and you reduce the teeth approximately 0.5 millimeter on the facial if it's a normal tooth color. I mean, if you had a presenting tooth that was very dark, then you'd reduce the facial about 1 millimeter. But you always want to be careful in the gingival 1/4 of the tooth, because that enamel is very thin. The enamel's only about 0.5 millimeter thick in the gingival 1/4. So many times I'll just polish the marginal part of the preparation and then finish the margin once I've seated the veneer, so you don't have an edge on the veneer, because you don't want to create a hypersensitive tooth if you can help it. So again, the coarse barrel diamond, I'm reducing these teeth about 0.5 millimeter. Now if you had a tooth that was crooked, that say this central was out of the arch alignment to the facial, and it wasn't very much out of the arch alignment, then you'd prep it back into the arch alignment and then reduce it a 1/2 millimeter. So you'd be a little more aggressive on that tooth that was facial verted. Now, if they're very crooked, if the teeth are very crowded, then obviously the patient should undergo orthodontic treatment prior to veneer preparation. So when you're prepping teeth for veneers, you want to round all the line angles except for the palatal or lingual line angles. So you round the facial interproximal line angles and the facial incisal line angle and the corners of the teeth. You want the incisal preparation part of the tooth to be flat, just like that, and the incisal palatal line angle to be a right angle. Don't taco the incisal palatal part of the preparation. You want that to be flat. That's the most sturdy veneer preparation. So see, I've cut my 1/2 millimeter depth cuts, and now I'm connecting them with this coarse barrel diamond. Lots of water. And then you want to round the incisal facial line angle, but you want this incisal palatal line angle to be 90 degrees. And you want that surface to be flat. By including the incisal surface of the tooth, when you seat the veneer, you have a stop. It makes the veneer stronger, and also you have a stop. If someone only prepares the facial of a tooth for a veneer and you try to place the veneer, it swims and you don't have a definitive stop. So you always want to stop on the incisal or the facial occlusal if it's a bicuspid. So rounding these corners, and then the incisal facial line angle and the facial interproximal line angles rounded. But the interproximal palatal and the incisal palatal line angles are right angle. Now I'm coming back with either a fine flame-shaped diamond or a fine chamfer diamond and placing the margins. And you don't want the preparation to be very deep in the gingival 1/4, because remember, the enamel's only about 3/10 to 1/2 millimeter thick in the gingival 1/4 of the tooth. And these preparations are about 1 millimeter subgingival on the facial, and they're about 1/2 millimeter subgingival interproximally. So about 1 millimeter into the sulcus on the facial and about 1/2 millimeter into the sulcus interproximally. Now this is another point. I constantly will stand up and look at the patient's face from the front, and you can see we've got these retractors, double retractors in place. And I want to see that the incisal edge of the central incisors is parallel to the pupillary line, a line drawn between the pupils. So my technician is oriented correctly. We'll be mounting this with a face bow, but unless this tooth is broken off or has a big composite, keep the incisal edges of the centrals parallel to a line drawn between the pupils. It's the fine chamfer. You can either use, sometimes I'll use a fine flame-shaped diamond, and sometimes I'll use a chamfer, but you can see how this prep comes all the way over to the incisal palatal line angle, but that line angle is 90 degrees. Then we've got crowns on the bicuspid and first molar because they had large fillings in the teeth. And I'll constantly look at the preparations with a large occlusal mirror and just see if the preps draw. See, I want that incisal preparation of the veneer to be flat. This is a study by Monnier and Douglas, I think back in 1999, that showed that these are the strongest veneers, and it does not compromise the strength of the natural teeth. You can link to this. Why should you prep or wrap the interproximal surfaces of veneers? Let's go through that. The advantages of wrapping, and when I say wrapping, that means including the interproximal surfaces and the incisal edges of the teeth. More precise veneer seating. When you seat the veneer, it doesn't swim. It goes directly to a definitive seat. The potential for future interproximal decay is virtually eliminated because now you've got porcelain or lithium disilicate or zirconia or whatever your restoration is made from on the interproximal surface, so you're not going to get interproximal decay. It's a more aesthetic restoration, especially with darker teeth. If you only prep the facial of the teeth and it's a dark tooth, you can have dark shine through in the interproximal if you don't include the interproximal surface of the teeth in the preparation. And the potential for post-operative interproximal staining is virtually eliminated. If you only prep the facial of the teeth, then with that preparation, dentists would prep about halfway through the interproximal, where there's a tiny little margin of composite between the tooth and the veneer in that little micro gap. And if a patient drinks red wine, coffee, anything like that, they can stain that little bit of composite because composite stains, and they can get that dark line between the teeth. Other advantages, the restorations are stronger. Studies have shown the preparation that includes the interproximal surfaces and the incisal edge, the veneers are much stronger than veneers that are only on the facial and much less likely to fracture. The provisional restorations are more secure. If you're trying to place veneers only on the facial surface, the patient's going to lose their provisional veneers repeatedly. During veneer seating, excess filled resin is more accessible to removal because when you seat the veneer, the excess filled resin is going to squirt out on the palatal or the lingual. So it's a lot easier to remove than if the margin is directly in the interproximal. The form, especially the width of individual restorations, can be idealized. Most people's teeth are not the perfect proportion. So if they're not, and you include the interproximal surfaces in the preparation, the technician can idealize the widths of the teeth with the final restorations. The technician can't do that if you only prep the facial surface of the teeth. And then finally, the preparation 99% of the time is still in enamel, so the tooth is not going to know the difference. The studies have shown the tooth is as strong as if you did not prepare the interproximal. The disadvantages of wrapping the incisal edge and interproximal contacts in veneer preparation: there's slightly more tooth structure removal, but it doesn't really affect the tooth. This is a study by Monnier and Douglas in '99. Our result is in accordance with previous work on natural teeth, which states that the reduction of proximal enamel, interproximal enamel, does not seriously increase the crown deformation, meaning it doesn't make the natural tooth weaker. It's concluded that the removal of facial and palatal enamel more seriously affects the strength of the teeth than the removal of interproximal enamel. That's why one of the worst things you can do is, if you don't have to, is place a post in a single rooted tooth that's had endodontics and going to receive a crown, because you're removing tooth structure all the way around the tooth and in the inner part of the tooth in the canal. So what this is saying is, if you remove a lot of tooth structure on the facial or the palatal, that can affect the strength of the natural tooth. It really doesn't affect it much if you remove only interproximal enamel. That's why I'm a big fan of veneers on anterior teeth versus crowns, unless there's some reason that you have to place a crown, meaning the tooth is either badly broken down or you're placing a bridge. There's just a lot less tooth structure removal. So these are the preparations. We've done crowns on the bicuspid and the first molar, and veneers on the cuspid to cuspid, the anterior teeth. And see how the whole thing draws, because you're going to seat the veneer. And then this incisal palatal line angle is 90 degrees. Don't round that incisal palatal line angle. This goes to the laboratory. This is a view of the incisal preparation and the patient's pupillary line. So the technician can see that the incisal edges of the central incisors are parallel to a line drawn between the pupils. We're sending him a face bone mounting so that when he mounts the maxillary cast on the articulator with the face bow, that mounted cast on the articulator should be the same orientation as the teeth in relation to the pupillary line. So the pupillary line represents the lab tabletop and the floor. So this orientation should be the same as the incisal edge of the mounted cast are on the articulator to the lab bench. This goes to the technician also. Lips in repose, if some tooth is visible, just to see that the incisal edges of the maxillary incisor teeth are parallel to the pupillary line. So I do the wax up prior to tooth preparation. Refer to this link, How to Fabricate Temporary Veneers, because we always wax them up thicker, because if you don't, this bisacrylate provisional material is so thin it's like working with wet toilet paper. So if you'll wax them up ahead of time, you've got a thickness of bisacrylate to work with. And we're going to fabricate this polyvinyl siloxane matrix off of the waxed up model. So refer to those videos in the library of dentistrymasterclasses.com. We've got all these in there that you can refer to see how to fabricate a provisional matrix, how to fabricate provisional veneers, crowns, whatever it is. So keep the tip of this bisacrylate gun in the bottom of the matrix and rub it against the bottom to decrease the surface tension so you don't get bubbles. Then wet the teeth, soppy wet, and squirt this on the teeth, keeping the tip in the material. But you want it wet for lubrication so it'll come off. When you're fabricating this polyvinyl siloxane matrix, be sure it also covers the palate, because if it only covers the teeth and you've prepped these teeth and you've reduced the teeth occlusally and incisally, and you push right here on the teeth, it's going to go too far to place. But if you've got polyvinyl siloxane on the palate, that's your stop. And you push on the palate, it'll stop the matrix so you don't push it too far onto the teeth. Now you're going to place retraction cord only on the facial and not deep into the sulcus, just lightly into the sulcus, just to reflect that sulcus. You can look at the video on retraction cord placement. We're going to take a polyether with custom tray and a reversible hydrocolloid impression. I always take either two reversible hydrocolloids if it's just one tooth. If it's two or more teeth, I take a polyether with custom tray and a reversible hydrocolloid impression. You can refer to the links in the library of Dentistry Master Classes and see how to do that. You always want to use a custom tray when you're taking a polyether or a polyvinyl siloxane impression. So we're squirting the body polyether into the custom tray, then putting the wash on top of it, wet the teeth. Now you can either squirt the wash material onto the teeth also, or just put the tray to place with the wash on the body polyether. Remember, polyether is hydrophilic. It likes water. Polyvinyl siloxane is hydrophobic. It doesn't like water. That's the reason I've stayed with polyether versus polyvinyl siloxane. We're working in a wet environment. I want an impression material that likes water. See, when you push this to place and you've got a custom tray, there's lots of force pushing that material up into the sulcus to capture those margins. You don't have that force if you've got polyether or polyvinyl siloxane in just a stock tray. They crisp, clean margins all the way around. Then I'm going to wet the teeth with warm water, and this is reversible hydrocolloid, which is also deadly accurate. You can watch the videos on both of those. Then just crisp, clean margins. Then we take a facebone mounting. You can look at the video on how to do that. Then a polyvinyl siloxane fast set occlusal restoration record only between the teeth that have been prepared. You don't put it on between teeth that have not been prepared, or it will give you an open bite record. So only put it between the teeth that have been prepared and the incisal or the occlusal has been adjusted. And these are the provisional restorations. Now, if I've prepped all the way back to the bicuspids, if it was only veneers, I would cut the provisional restoration into three parts: cuspid through bicuspids and lateral incisor to lateral incisor. Because if they're all veneers and you have them all in one piece, the bicuspids are going to fan out like a starched shirt. Now in this case, this is going to be really stable because I have crowns on the bicuspid and the first molar. So it's going to be a really stable provisional, but they're easier to seat if you have them in 3 pieces. So this is unfilled resin. This is just only adhesive. There's no primer in this, and we've not etched the teeth at all. So you put the primer in the anterior part of the provisional restoration from cuspid to cuspid. So I've broken off the bicuspid and the molar on each side. I'm going to seat this provisional in 3 parts. It's easier to seat that way. Trust me. I'm going to push it. I've just dabbed the teeth dry, and then I'm wiping some of that adhesive on the surface of the provisional restoration, then blowing off the excess onto a 2x2. Place a 2x2 in the mouth so you're not blowing that excess unfilled resin onto the gingival tissue or the adjacent teeth. So blow it off on the facial and the palatal, and then place your provisional cement in your crown provisionals. I always put the seat veneer provisionals or veneers prior to seating the crowns. Then you're going to cure this, and I cure the provisional restorations with the adhesive 20 seconds on both sides of each restoration. Then you're going to remove your excess provisional cement. Don't wait too long, but it's very important that you wait till the cement has initial set so it peels off and doesn't wipe off. Then we're going to connect the 3 parts of the provisional with flowable composite and cure that. Check the occlusion, adjust it with whatever burr you like. This is a slow speed occlusal reduction diamond, and then I'm going to polish with a Shofu rubber wheel. There's provisionals. Final restoration we're going to go through next time. That's the Dental Minute. These techniques work, and they work every time.
Take your practice to the top tier. Subscribe to dentistrymasterclasses.com for an organized library of all the Dental Minute videos, plus many complete comprehensive cases and many very important articles. New cases are added weekly, only $20 per month. Subscribe now.